So this is the third in the series of immunology podcasts, and it's going to be on autoimmune disease. I've decided to split this up into two parts. In the first part, I'm going to consider the basic mechanisms of autoimmune disease, the Jelen-Coombs classification and how this relates to autoimmune disease, and then finally look at some of the prototypal autoimmune diseases. In the second part, I'm going to consider the investigations that are necessary for the diagnosis of autoimmune disease. So at its most basic level, autoimmune disease results from a failure in the acquired immune system, leading to a response against host antigens. This may occur for central or peripheral reasons. Central reasons really are because there's a failure to delete autoreactive T cells in the thymus or B cells in the bone marrow, while peripheral tolerance can be lost because there is reactivation of weakly autoreactive T or B cells, usually due to inflammation, infection, or tissue damage. The etiology of autoimmune disease is exceedingly complex with multiple factors implicated. Genetic factors include sex differences, family histories, and various associations with types of HLA alleles. For example, ankylosing spondylitis is associated with HLA-B27, rheumatoid arthritis DR4, type 1 diabetes DR3, DR4, and Goodpasture's syndrome DR2. In addition, environmental factors are important, and these include, most importantly, infections, which can act by breaking tolerance through mechanisms such as molecular mimicry and hyperstimulation of co-stimulating factors. The type, location, and specificity of the immune response influences the pathologies that we see with the autoimmune diseases, and we can classify them most basically into organ-specific autoimmune diseases and non-organ-specific autoimmune diseases. Examples of organ-specific diseases would be Graves' disease, pernicious anemia, Addison's disease, while prototypal non-organ-specific autoimmune disease would be SLE and rheumatoid arthritis. The most useful way of looking at the pathogenic immune mechanisms of autoimmune disease is to consider the Jelen-Coombs classification. Type 1 is IgE and is not going to be considered here. Type 2 is an antibody-mediated process. Type 3 is an immune complex-mediated process. And type 4 is a T-cell-driven process. It's important to note, however, that there usually is some crossover between all these reactions. So, in type 2 hypersensitivity, IgG or IgM antibodies react with self-antigens and result in three patterns of disease. They either cause tissue damage due to complement fixation, neutrophil activation, and excessive inflammation, or they cause receptor blockade, resulting in tissue dysfunction, or they can cause receptor activation, leading to excess function. Diseases associated with tissue damage include autoimmune hemolytic anemia, where antibodies are directed against various erythrocyte membrane proteins, autoimmune thrombocytopenic purpura, when antibodies are directed against platelet membrane proteins, pemphigus vulgaris, where proteins are directed at cadherin in the intracellular junctions of epidermal cells, acute rheumatic fever, where antibodies formed following a streptococcal infection can deposit in the heart and various other tissues, and Goodpasture syndrome, where antibodies are formed against type 4 collagen present in the basement membrane of the kidneys and also in the lungs. An example of a disease caused by receptor activation is Graves' disease, where antibodies against TSH receptors result in excess thyroid being produced and hyperthyroidism, and examples of blockade leading to dysfunction include myasthenia gravis, where antibodies inhibit acetylcholine binding, causing muscle weakness and paralysis, and pernicious anemia, where there is neutralization of intrinsic factor, and hence decreased absorption of vitamin B12. In type 3 hypersensitivity, there is immune complex-mediated tissue damage due to binding of IgG/IgM against soluble antigens in the blood, formation of complexes, deposition in tissues, and then subsequent complement fixation and activation of an inflammatory reaction, ultimately resulting in tissue damage. Importantly, diseases associated with type 3 responses have three pathologies. These are vasculitis, nephritis, and arthritis. In type 4 hypersensitivity, there are two separate processes that may occur. These are delayed type hypersensitivity, which is a CD4 plus Th1 mediated process driven by exposure to antigens by antigen-presenting cells, production of IL-12, then further secretion of interferon gamma, IL-2, tumor necrosis factor A, which act to recruit further phagocytes to the site of exposure, and ultimately, if the antigen is non-degradable or persistent, leading to the formation of granulomas characterized by epithelioid macrophages. Type 4 responses may also be CD8 T-cell cytotoxic driven, with perforin and Fas ligand attacks on cells. In physiology, this is usually directed towards tumours and viral cells, but may become overactive in this type of response. Important diseases associated with type 4 responses are MS, type 1 diabetes, contact dermatitis, transplant rejection, and tuberculosis. So now, in the second part of this podcast, I'm going to go on to talk about some of the features of the prototypal autoimmune diseases. First of all, I'm going to talk about SLE, which is a systemic autoimmune disorder characterized by the presence of numerous autoantibodies. The most common autoantibody present is the antinuclear antibody, or ANA, which can have a number of patterns determined by immunofluorescence. These are homogeneous, peripheral speckled, and nucleolar. Other very important antibodies are the anti-double-stranded DNA and anti-Smith antigen antibodies, and all three of these together strongly suggest SLE. In addition to ANAs, SLA patients produce other antibodies that may be directed against blood elements, phospholipid-associated proteins, and against various components in the coagulation assays. The phospholipid ones are called antiphospholipid antibodies, and the ones directed at the coagulant cascades are lupus anticoagulants. These are important because they cause a procoagulant effect, resulting in recurrent vascular thrombosis and miscarriages. Pathogenesis of SLE is driven predominantly by type 3 response, but there may be type 2 hypersensitivity, for example, in SLE patients who produce autoantibodies directed against red cells, white cells, or platelets. As organ damage is mainly mediated by a type 3 response, there is acute necrotizing vasculitis and fibrinoid deposits. The most common organ to be involved is the kidney, but other organs include the skin, where there is classical malar erythema over the bridge of the nose, the so-called butterfly rash that's exacerbated by sunlight, joints causing non-specific non-erosive synovitis, the central nervous system, probably secondary to endothelial injury and occlusion due to antiphospholipid antibodies, but that causes various neuropsychiatric manifestations, the cardiovascular system causing pericarditis and less commonly myocarditis. Liebman-Sachs endocarditis is the formation of non-bacterial verrucous vegetations, most commonly on mitral or tricuspid valves. In the lungs, pleuritis is common, as is interstitial pneumonitis and diffuse fibrosing alveolitis. Most patients with lupus suffer recurrent flares and remissions. Two less important forms of lupus are the chronic discoid form, associated with cutaneous lesions that mimic SLE, and drug-induced lupus, which is associated with hydralazine, procainamide, isoniazid, and pelicitinamine. This may be severe enough to cause multi-organ involvement, but commonly remits after removal of the offending agent. So that completes part A of this third podcast in the Immunology series. So this is part 2 of the third Immunology podcast, and is going to be about the diagnosis of autoimmune disease. I'm going to look at the use of antinuclear antibodies, extractable nuclear antigens, anti-DNA antibodies, complement, antiphospholipid antibodies, anchors, and rheumatoid factor. Autoantibodies are often characteristic of autoimmune disease, and the amount of autoantibody is measured usually by titer. So results come back as a fraction, so 1 in 80, 1 in 160. Obviously, the greater the second number, the higher amount of antibody is present. It's very important that autoantibody tests should be ordered with reference to the clinical picture of the patient. So there are a number of different types of autoantibody. The first ones I'm going to talk about are the antinuclear antibodies, or ANAs. These are a group of antibodies that, as the name suggests, binds to components of the nucleus. An antibody titer of greater than 1 in 80 is usually considered positive. However, it should be remembered that 5% of normal people will have this result. The most useful indication for ANA testing is the diagnosis of SLE, as nearly 100% of patients with SLE have this condition. A negative ANA test, therefore, pretty much excludes the diagnosis of SLE. A positive test, however, can be due to a number of other problems, the most important of which are scleroderma, Sjögren's syndrome, dermatomyositis or polymyositis, mixed connective tissue disease, and autoimmune hepatic disease. There is no role for serial monitoring of ANA titer in any of the autoimmune diseases. Also, the ANA pattern, as determined by immunofluorescence, are associated with specific clinical subgroups of autoimmune disease. 2 examples: the speckled ANA is associated with SLE and Sjögren's, and nucleolar ANA is associated with scleroderma. So, if you have a positive ANA test, it's useful to try and establish which particular nuclear component is being recognized, as this can help to narrow down the disease process. These nuclear components are called nuclear antigens and can have high specificity for individual disease subgroups. There are quite a few of them, so I'm going to run through the most important ones. The anti-centromere antibody is associated with the CREST variant of scleroderma, antihistone antibody with drug-induced lupus, anti-Jo1 with polymyositis, dermatomyositis, anti-LAR in association with a speckled ANA and the diseases Sjögren's syndrome and SLE, anti-ribonucleoprotein antibody, anti-RNP, associated with mixed connective tissue disease and SLE, anti-Rho antibody, associated also with a speckled ANA, anti-Smith antibody, which is very specific for SLE and is associated with a more benign prognosis, an anti-topoisomerase 1 antibody, or anti-SCL70, associated with diffuse scleroderma with severe organ involvement. The next group of antibodies are the anti-DNA antibodies, which are formed against double-stranded DNA. These are highly specific for SLE, are useful in disease monitoring of SLE, as higher levels are associated with disease activity and relapse, specifically renal and central nervous system involvement. The presence of antiphospholipid antibodies may be either primary in the primary antiphospholipid syndrome, which is unassociated with other autoimmune phenomenon, or secondary, the secondary antiphospholipid syndrome, which is commonly associated with SLE. These antibodies are specifically associated with the development of venous and arterial thrombosis and recurrent miscarriages. There are two major ways of measuring them, either with the anti-cardiolipin antibodies or the lupus anticoagulants. Specifically, the lupus anticoagulants are associated with excess procoagulant activity. The next group are the anti-neutrophil cytoplasmic antibodies, or ANCAs, and these are specifically associated with systemic vasculitis. There are two important ones: C-ANCA, that's associated with Wegener's granulomatosis, specifically Wegener's with renal involvement; P-ANCA, which is associated with microscopic polyarteritis. Lastly, I'm going to look at complement and rheumatoid factor. First of all, let's get rheumatoid factor out of the way. Rheumatoid factor is a bit of a misnomer. It's actually an antibody that's directed against the common Fc region of human IgG and is associated with a wide variety of autoimmune and non-autoimmune conditions, and is a very common finding in the elderly. As it's so non-specific and non-sensitive, it's not really useful for the diagnosis of rheumatoid arthritis and can therefore not be used to rule out this diagnosis. However, it is useful in evaluating prognosis in patients with rheumatoid arthritis, as rheumatoid factor positive patients typically have more severe erosive disease and extra-articular disease manifestations such as vasculitis, nodules, and Felty syndrome. Complement C3 and C4 quantification is very useful in the evaluation of immune complex-mediated diseases, and it's important to remember that the unactivated forms of these are measured. They are used as surrogate markers of immune complex deposition, as classical complement pathway activation leads to a decrease in circulating C4 first, then later on, when it gets more severe, decreased C3 levels. And this really explains how serial measurements of C3 and C4 are useful in the monitoring of SLE. As with active SLE, there will be a normal C3 and a reduced C4. With very severe SLE, there will be reduced C3 and C4, and in active, both C3 and C4 will be normal. So this completes the podcast on the diagnosis of autoimmune diseases. For further information about some of the other autoimmune diseases and the specific features associated with them, go and have a listen to the cellular pathology podcasts.